Okay, good morning, everybody, and thank you for joining us on this co-hosted webinar between the Institute for Healthy Living and Chronic Disease Prevention at UBC and North Okanagan Hospice Society. My name is Clara Dick. I'm the Education and Resource Leader here at North Okanagan Hospice Society, and it's my pleasure to host the BC Centre for Palliative Care today. But before we begin, I would like to respectfully acknowledge that UBC Okanagan and the North Okanagan Hospice Society is situated on the traditional, ancestral, unceded territory of the Silk Okanagan Nation. I would also like to acknowledge that you are joining us today from many other places, near and far, and acknowledge the traditional owners and caretakers of those lands. I also just want to personally offer my humble thanks and acknowledgement. These nations, their care of the land has made where we live, work, and play an amazing place to live, work, and play. But it's also made it a very good place to die. So I offer my humble thanks and acknowledgement for that. Closed captioning. So the closed captioning box can be moved to your preferred place by clicking and dragging it where you would like. Or turned off by turn off closed captioning. Select the hide caption button on the menu bar. Throughout the presentation, if you have any questions or comments, go ahead and pop those in the chat box. I'll be monitoring those, and then we'll address any questions or comments at the very end between the three of us. So today's event is a Research to Practice webinar, and again, it's co-hosted by the Institute for Healthy Living and Chronic Disease Prevention and North Okanagan Hospice Society. It's my pleasure, absolute pleasure, to introduce Dr. Eman Hassan, the Executive Director of the BC Centre for Palliative Care. She's Adjunct Professor, Faculty of Medicine, UBC Division of Palliative Care. And Simon Anderson, the Research Coordinator at the BC Centre for Palliative Care. So these two will be sharing today on Clarity Achieved, a unified definition for care provided in BC's hospice societies. So I'm going to turn it over to you two.
Thank you so much, Clara, and I really appreciate the opportunity that's been given to us to share our the process that led to this important milestone for the hospice and palliative care community in BC. Thanks to Jagada and Jennifer and Clara for all the support, and also for reaching out to us and for this kind of invitation. And I'm really pleased to have Simon, who has played an instrumental role in the research methods involved in the project that led to the development of this common definition. And I'm sure that many of you have seen the joint announcement that went out earlier in the year, specifically on January 23rd, from the BC Centre for Palliative Care and the BC Hospice Palliative Care Association regarding the release of a consensus common definition for the care provided by hospice societies in BC. I'll talk more about this, but let me first start by my part of the presentation with a land acknowledgement on behalf of my team at the BC Centre for Palliative Care. We acknowledge that we are living and working with humility and respect on the traditional territories of the First Nation peoples of BC. We also recognize the Métis and the Inuit Indigenous peoples living across our province on various traditional territories. I'm joining you today from the ancestral and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations, and I'm really grateful for the opportunity to live and enjoy this beautiful land. As you probably know or participated in this project as a clinician or as an organization. So I'm really interested to know if you can let us know in the chat if you participated in the project as one of the panel expert, the expert panel that participated in the surveys, the multiple surveys of the Delphi process, and contributed to this common definition. So let us know. I'm really curious to know that. This definition is actually the result of a 2-year project using a consensus building research methods, and I will talk more about that. But the project was co-led by the BC Center for Palliative Care and the BC Hospice Palliative Care Association, and we brought together hospice societies, palliative care experts, individuals with lived experience, and community partners. And this is the strength of this project. In our presentation today, we will be sharing with you the process by which we created the definition, and we'll go over the methods and the results, and this is Simon's role or part, and we will have time to answer any questions you might have about the process or the definition itself. And hopefully in the chat you can share your perspective on the final definition. Does it resonate to you? Your own understanding, if you are not part of the hospice community, but you are an important partner. So we would love to hear from you. Before we go through the process, let's share with you the background. What prompted us to create or initiate or launch this project? Just to understand the landscape of the hospice societies in BC, currently we have over 70 hospice societies spread across the rural and remote and urban areas in our province. And those hospice societies, they offer a wide range of services to roughly 10,000 people per month on average. This is this information was gathered through a current state assessment of the hospice sector that the BC Center led in 2019, I believe, or 2019, 2020. And what we learned through this current state assessment is that the services provided by hospice societies involve a wide, as I said, wide range of support services for people with life-limiting illness, those at end of life, and grief and bereavement care and support, and also social support for family caregivers. Their services are delivered largely by a volunteer workforce. And again, this is another strength. It's an asset that the hospice society rely on the community resources to deliver these services. And the volunteer workforce are well-trained and supported by by healthcare professionals. Despite this important role that the hospice society play in supporting the well-being of the communities, of the people, individuals, and families, there's lack of clarity among the public and healthcare system and the community at large regarding what the play that that the hospice societies play, and also the services they provide. Many people, unfortunately, mistakenly think that these hospice societies only run inpatient facilities for end-of-life care. And in fact, only a small number of hospice societies have a facility that provide around-the-clock clinical and medical care for people who are at end of life. So this problem, basically, impact, this is what we learned, that it impacts the use of the hospice society services and limit the potential or the full potentials of the hospice society's role and accessibility. In 2020, a report titled Hospice Care in British Columbia, The Path Forward, was released. The report presented or presents a 10-step action plan aimed at enhancing and maximizing the role of hospice societies in BC. Among the recommended actions are the need to enhance awareness of hospice societies and to develop a common definition that could be universally used across hospice societies, government, the healthcare system, and other community partners. The report was released by a group called Provincial Hospice Working Group in BC, and we are very proud to be a member of this group. Now, this group is now renamed or called the Hospice Care Alliance Steering Committee, and this group basically served as the steering committee for this project. The report was informed by Gray and published literature review, by survey with administrators of hospice societies, and by recommendations from the 2019 Provincial Roundtable on Hospice Care in BC. So as you see here in the image of the 10 steps, the step number 4 is the one that calls for the creation of a standardized definition for hospice care. To fulfill this specific action, in April 2022, the BC Centre for Palliative Care and the BC Hospice Palliative Care Association launched this project with the aim of developing a common definition for the care provided by all hospice societies in the province, not just a specific or one hospice society. This is an important clarification because for example, hospice societies might, look at the definition and said, well, we are not providing all this spectrum of services, but this, again, they could adapt. We can talk about this at the end, but this is just a clarification that it's a definition for the care provided by all hospice societies in our province. And Simon will walk us through the methods that we use to develop this definition.
Thanks, Eman. Yeah, so nice to meet you all. Glad you could make it here today. And my name is Simon. I'm the research coordinator. And like Eman said, I'll talk about the methods for this project, how we came to reach consensus on this definition. So our process began with an environmental scan done in the summer of 2022. And the purpose of this scan was to identify any existing definitions of care related to hospice societies that are already in use, either in published literature or in Gray literature. And then from these current definitions, what we did is we recorded them and analyzed them for attributes of hospice society care so that we could begin our Delphi process with a collection of attributes that experts could review. And so once this scan was completed, we began our Delphi process in November. And then our process essentially involved iterative surveys where experts provided feedback on attributes that we had found in our scan, like I said. And then they also suggested new attributes that maybe didn't already exist in current understandings of hospice care. And then future surveys also then settled on the wording of those attributes, and eventually we determined the definition structure with the panel for 3 versions of a final definition: a short version, a medium version, and a long version. And I'll talk about those versions more later. And then finally, yeah, we concluded our process in October with a high level of consensus on those final definition versions. For people who maybe are unfamiliar with what a Delphi process is, essentially what it is it's a method that uses repeated surveys with experts to get their opinions on an issue or topic. So a couple of things that are really important about it. The first is that it's anonymous. So we as the research team know the identity of the expert panel, but they don't know the identity of each other. And so any answers to survey questions are kept de-identified from other participants, and the results of each survey are always presented back to the participants by the project team. So with all this in mind, our environmental scan, as I mentioned, allowed us to provide kind of a starting point on some attributes of hospice society care that experts could then assess for inclusion, or they could suggest additional attributes or alternations or alternative attributes. Surveys 2 to 5 then continued to refine which attributes were to be included and what their wording and structure could be. And then in survey 3, we also asked experts to rank the attributes in terms of importance. So what they felt to be the most important things that would be needed in a public definition of hospice society care. Because not every attribute could fit in those smaller versions. And like I said, I'll talk more about those versions in a bit. Survey 4 and 5 then allowed us to propose and revise the final full, medium, and short definition versions. And then survey 6 was the final survey where experts either endorsed or did not endorse the final definition versions. For our expert panel, we had 56 panel members made up of 2 groups. The first group was anyone associated with a hospice society. We referred to them as the hospice group. And then there was the second group was anyone outside of the hospice societies. So those were referred to as the external group. They included medical professionals and palliative care physicians and those types of people. To recruit panel members for our hospice group, a request for expressions of interest were sent out to 71 community hospices across BC, describing the target recruitment of 18 executive directors, 7 volunteer coordinators, 7 counselors, and 7 volunteers, and 7 board members from hospice societies in BC. We received 33 responses from 24 different hospice societies that had expressed interest, and then a total of 22 hospice societies were actually represented when we began our process. We were open to having up to 47 hospice participants, and so we accepted everyone that expressed interest. No more than 3 people from any single hospice participated. 2 of our hospices had 3 people, and 5 of our hospices had 2 people, and the rest just had 1. To recruit participants for the external group, specific candidates that were known to the project team and our network as the BC Centre for Palliative Care were individually invited to take part in this project. And then we also invited people with lived experience of receiving hospice services through Reach BC. Important to note, so for the Delphi process, what we do to determine consensus is people have to agree at a certain level. And so what we did is we defined consensus. We decided that consensus would be defined as 75% agreement across the entire panel, so those external members and those hospice society members, and 75% agreement just within the hospice society. So that's 2 criteria that was needed for one of those items, one of those attributes, or a wording of an attribute to be considered as having met consensus. Just some feedback and evaluation that we had received from participants in our process. It was generally a very positive experience for our participants, which is great to hear. People felt that our process surveys and instructions for each of those surveys were very clear. 95% of people agreed on that. 98% of people did feel like they had sufficient chances to give feedback throughout the process, and 84% of people felt that their feedback was adequately reflected during the process. And these are just some comments from people saying the process was an effective collaboration that allowed for important fine-tuning to identify what hospice is all about. Another person said, I liked reading the comments by other participants. It helped me to clarify my ideas about meanings and inclusivity of terms. So we were really encouraged to see that feedback that we received at the end of the process. And I think it lends strength to the process as being a really valid way of identifying, what really, when we talk about hospice society care, what are we really talking about? So without further ado, I can talk about the results now. So the final definition, our 6-round Delphi process successfully reached consensus. on a definition of care provided by hospice societies in BC. And partway through our process, like I said, we determined that having 3 versions of our definition that differ in length would provide some adaptability and flexibility for this definition to support its uptake across the province. And over the course of our surveys, our response rates range from 87 to 100%. And we ended up with an 85% consensus rate, both in the total group and in the hospice specific group across our 3 definition versions, which we were really happy to see. So this is our full definition. Like Eman said, you may have already received from us or from the BCHPCA a notification about this definition being released. I can just read it out. So hospice societies provide support and care for people living with life-limiting illness and for people at the end of life, family and friends, and others affected by life-limiting illness or death. They also provide support and care for people experiencing bereavement and those who are grieving. Hospice Society support and care aims to enhance quality of life, provide comfort, and ease suffering while maintaining people's dignity. Hospice societies provide emotional, social, practical, spiritual, and grief and bereavement supports. Hospice societies use a whole person approach that is person and family centered. Their support and care are provided with compassion and recognize and respect the diverse aspects of a person's identity and culture. Specially trained staff and volunteers deliver their support and care in a variety of settings, including the person's home, long-term care facilities, assisted living facilities, hospice facilities or residences, hospitals, virtual platforms, or other community locations. Hospice societies are part of a broader system of formal and informal supports. In British Columbia, the services hospice societies provide and the way they provide them can vary depending on which community they serve. Hospice societies are not the same as a hospice facility or residence, which provide 24-hour medical care for people with palliative and end-of-life care needs. Only a few hospice societies operate a facility or residence. So a couple things with noting this definition. So it's important to remember that this definition, like Eman said, is meant to describe all hospice societies in the province as a whole. So it's not necessarily going to apply as written to an individual hospice society. And another thing to note, obviously, is that it's quite long and a bit of a mouthful. And so it's maybe not practical to use all the time in all situations. And even beyond that, for individual hospice societies, they may choose to modify this definition version for their individual use to make it accurate to their activities and services. And so while people can pick and choose, which sections to use, we wanted to provide predefined shorter versions of the definition to make things easier to select when people are actually using this definition. And so that's why we ended up having this medium version and a short version of the definition, which I'll talk about next. So how did we get to these shorter versions? Well, we did prioritization. So this is what I was talking about in survey 3. We asked people to rank the most important components of the definition with the understanding that the most important components would make the cut, so to speak, into the shorter definition versions. So this is just a slide showing exactly this. So down below, you have the different components. So we have people served, aims, philosophy, supports provided, providers, location, variety among organizations, and different to hospices. So those are all the components that had reached consensus. Everyone in the process said these components are important to include in the definition. But then our next question was, how important? What's the priority of each of these when putting them into a definition? And so this graph shows people's rating. And so the lower scores are a higher priority. So thinking like on a scale of 1 to 7, 1 being your first choice. So what we see is that there's a very obvious grouping that shows up when we asked people. People said people served, aims, philosophy, and supports provided are the most important things that people need to know about when it comes to hospice society care. And so what we did is we selected these 4 components to take to put into a medium and a short version of the definition. So that full version that I just read has everything, has all those components. The medium and short versions just have these 4. But something to note is that we felt as we were designing this definition and as we were reading comments from people, this idea of philosophy the philosophy of hospice society care is actually quite adequately captured in the people served, in the aim of the care, and in the supports provided. So we felt that philosophy didn't need to be explicitly mentioned when we're also talking about these three other components. And so we ended up with a medium version and a short version of the definition. So the medium version reads, hospice societies provide emotional, social, practical, spiritual, grief and bereavement support and care. They aim to enhance quality of life and maintain dignity for people living with life-limiting illness, those at the end of life, as well as families, friends, and others affected by life-limiting illness or death, as well as those who are grieving. The shorter version reads, hospice societies provide emotional, social, practical, spiritual, grief and bereavement support and care to enhance quality of life and maintain dignity for those living with or affected by life-limiting illness or death. So those are the versions. So you can see those three components show up compared to the full version, which has everything in it. One thing I did want to talk about as well is just this idea of tension points. So in the in the Delphi process, something that the Delphi process is really good at is teasing out differences in opinions between experts. Because what we do is we receive the opinions from people. We, as a project team, analyze them, read over them, and along with comments from people, we can kind of then represent these themes, these ideas back to the group and say, well, some of you thought this, another group of you thought this. And so how do we kind of reconcile these kind of differences? And so I wanted to show some examples of some tensions because obviously with hospice society care, there is so much nuance. There's such an importance of really defining what exactly we're talking about. And so one of these things was people serve, this idea of who is hospice society care actually serving. So a repeated theme throughout our process was that hospice societies, from a lot of people, like Eman was saying, are generally thought of as delivering end-of-life care, and oftentimes medical care, end-of-life care for people at the end of their life. However, it was really interesting because a lot of the hospice society representatives actually said, you know what, we provide more care to people who are bereaved. We provide more care to people who are grieving. And the people at the end of life is actually a smaller portion of the audience that we serve compared to, or the clientele that we serve compared to maybe what other people think. And so it's also, that was just really interesting for us to be reading as a project team. And it was also interesting because it lined up with what we saw in our environmental scan. We saw that only 12, so only 20% of the definitions that we saw in the environmental scan explicitly mentioned concepts of grief and bereavement, only 20% of them. But here we had the hospice representatives really kind of pressing on this point that hospice societies do provide more more care for people who are grieving and bereaved, and that is kind of an unrecognized or poorly recognized part of the clientele of hospice societies. And so some people left some really interesting comments related to this, and I'll just read them out. So one person, these are all these three comments are from people who represent hospice societies. So one person says, I think it's extremely important that the short definition include providing care and support to people living with life-limiting illnesses and those experiencing grief or the bereaved. This is actually the population hospice societies serve, as they are actually more grief and bereavement societies in BC, especially than hospice societies. This needs to be included in any and all definitions. Another person said, our grief support services grow every year in response to the growing rate of toxic drug, suicide, etc. deaths in our community. We receive many referrals from mental health, victim services, and local GPs. And one person even said, we are considering adding a tagline of Center for Grief and Loss to our hospice society name to better define our services. So we're hearing from these participants that in order to really actually adequately and properly define what they're providing, grief and bereavement definitely needs to be included, even though in our environmental scan, that was such a small part of the current understanding of hospice society care. So what we did in our process then is we took these comments, we represented them back to the group, and we said, you know, a lot of the external representatives, the people who work in the healthcare system, they're not commenting on this need for grief and bereavement to be included, but the Hospice Society representatives are really feeling it's necessary. So we showed that back to the group, and then eventually grief and bereavement was accepted with a high level of consensus once people began to click and kind of realize, oh, this is really important, and maybe they're not actually only for people at the end of life. So that's just kind of a cool example of how these tensions are kind of reconciled through our process. Another example is this idea of supports provided. So what the hospice societies are actually doing, what supports they're actually providing, what services they're providing. And so in survey 2, the concept of physical needs met inclusion, but the wording didn't. So the idea of physical needs was accepted. People said, yes, we do provide care for physical things, but we don't care for physical needs in that wording. And so there's this nuance that was observed between needs and supports, whereby hospice clientele might have physical needs, but they're not necessarily given medical care. They're not necessarily giving care for those physical needs in the same way. And so what we saw in this comment, especially, I'll read it out. So this person says, physical needs is too extensive for a volunteer role. However, informing an appropriate caregiver of the physical is something a volunteer would be expected to do. This would be included in practical supports and may need to be specifically addressed. So there's this kind of nuance between practical and physical and needs and supports. So for physical needs, you provide practical supports. So again, we repropose that to the survey group, the expert panel, and that was met with consensus. And so that's now included in our definition. So I hope that kind of highlights some of the ways that the process and the project team, we really worked through a lot of these comments. We received a wonderful depth of knowledge in these comments that highlighted all these different aspects and all these different opinions that that we wouldn't have gotten if we only looked at the numbers, or if we only looked at including certain ideas. So it's a really interesting process. And I feel like we as a project team are quite confident that we did get to a lot of the deeper meaning for a lot of these words. And so with that, I'm going to pass it back to Eman, and so we can talk about some of the next steps for what this definition means to the province.
Thank you so much, Simon. The tension points that Simon shared with us today, these are just examples of the tension. We had we experienced multiple or numerous ones throughout the surveys, and that actually enriched the discussion and the feedback and even our own learning experience as project team. So I really appreciate the opportunity of being part of this project as one of the project teams. Something that I would like to share with you that I think would also involve you is that we intend, the BC Center and BC-HBC Association, we intend to review the definition after 2 years to see if there are any changes or updates that's required based on people's experience or use of the definition. So we welcome any feedback at any point in time, including now or after the webinar. If you want to email us your feedback, that would be great, or even in the chat box now when we will have this a conversation or discussion about your how you see or relate to the definition. How does it resonate to you as a clinician, or does it align with your understanding? And we will also after 2 years, or when the time for the review comes, we will reach out to our partners and subscribers of our the newsletter, asking for their feedback. So if you want to be involved or participate in this review, please make sure that you are subscribers to the BC Centers newsletter and also the BC Hospice Palliative Care Association newsletter, where the call for feedback will be included. So what is exactly we are hoping? Now we have a consensus common definition. So what are we hoping in terms of next step? As I mentioned in the at the beginning of my presentation, is that we aim to standardize the terminology. We want to make sure that everyone in our province use this common definition, because that will help, will enable hospice societies to be utilized to their fullest potential. So I really encourage you to use the definition in any material that or document or resource, whether it's for the public, for example, if it's if you are a community organization or a hospice society, use this definition that relates to you, that describes your an adapted version of the definition in any public information materials, or if you in your staff orientation and training cite the definition in any communication, for example, or advocacy materials that you will be submitting to your politicians or to governments. So let's start using the definition broadly, because at the end of the day, what we are hoping is that we want to support the hospice societies who play a very unique and important role in enhancing the quality of life and the experience of people going through challenging events in life, whether it's a serious illness, life-limiting illness, and death and dying and loss. So with that, I would just hand over the floor to Clara, and thank you so much for listening to us and being here. I look forward to any questions you might have in the chat.
Excellent. Thanks, Eman and Simon. That was wonderful. So interesting to hear the process that you walked through. We were one of the hospices that participated, and so the research side of me is really like, oh, that's so amazing how you like walked through all that. And I spoke with Pablita at BC Hospice Palliative Care Association, so she shared a little bit about the process as well. Well done. So now's the time. Yeah, Jaquetta, just any questions or comments? If folks want to pop their questions in, we'll bring those up as they get entered. And Eman, if you don't mind if I start you off with a
This is a very interesting question and important as well. I think palliative care also would benefit from having a standardized definition, because again, the public understanding of palliative care is very limited. First of all, there is lack of awareness about what palliative care means, and also its association with end-of-life care, limiting the scope of that. Although the definition by the World Healthcare Organization, it's very broad. It's broader than that. It's not limited to end of life. It encompasses care provided for people who are experiencing life-limiting illness and for family, and it describes all the components that enables focusing on the physical symptoms and the pain and any distressing symptoms, but also the psychosocial aspects of the contribute to the quality of life. And but this is something that as I said, it's not only the public who mistakenly also associate palliative care with end of life, but also the healthcare providers, the clinicians. And still our healthcare system is not structured around this definition. It's still, the palliative care programs are only limited to people at or approaching end of life. So I see that this is a terminology that would benefit a lot from being standardized across our province.
Absolutely. That brings me to palliative care and most hospices. You mentioned the 71 hospices in BC. Most hospices work with advanced care planning and providing workshops. And so I suspect it would be helpful to have palliative care defined so that it could help people with the education around advanced care planning as well. Simon, this one question is maybe a little bit more for you because your research background. Do you see that we could maybe replicate, because you've done the process in BC, you've engaged all the partners, and now that you know how it works here, do you think we could replicate this in different
engage people in a certain area who have the expertise that maybe a regulating body or a health authority or a health organization doesn't. These people who have their boots on the ground, so to speak, who are really understanding, like those hospice participants in our process who are saying, we provide more care for grief and bereavement, actually. And there's kind of this disconnect that's realized. So I think in every area where there is that disconnect, which after having worked in palliative care for only a few years, but it's been pretty clear to me that there are definitely discrepancies between community care and the health system in different ways, where people have different misunderstandings, like Eman said, whether it's in more terms or whether, like you're asking, it's a different location. I definitely think those misunderstandings are common. And so I think having a process where you can bring together people who have the knowledge and the experience that you don't, that's what's really cool, I think, about the Delphi process specifically, and this kind of idea of getting people together to actually figure out what are we talking about when we mean palliative care, or what are we talking about when we mean hospice society care. And so I certainly think that it can be replicated. In terms of where it could be replicated, I would say anywhere, probably anywhere. But I also think that this process, our process, some of our services as well, could we use it? So I do think that while this process could be replicated, there's also a chance for collaboration and sharing of work that's already been done, and then adapting it to that context, to wherever is needed, wherever someone is noticing this gap between what they're saying and what is actually happening for these terms. Yeah.
Oh, that's so interesting. And I love that already there's the move to collaborate across Canada, because you're mentioning differences in BC. So for example, the hospice I work at, we have a hospice house, so we have a residence, and this definition applies to us. But I'm, shout out to Northern BC, Terrace is on the line. It also applies to the work they do. And so that's really what it brings is a strength to the hospice care provided in BC. Really curious about You were context, I guess, is after the pandemic, there was, the Canadian Grief Alliance was started through Canadian Virtual Hospice. And do you see that that has really changed and impacted the hospice societies and that real focus on grief and bereavement? Or do you think that it's just always been our standard work? Either of you.
I might let Eman start off on that.
Can you elaborate more on the question? I didn't get it.
Oh, okay. Yeah, for sure. So one of the tensions was really focusing on the grief and bereavement population. And do you think that tension has increased or changed in the last couple of years? Or do you think that it's always been so?
I don't know the answer for this question, because I was surprised myself to see that the non-hospice group in our expert panel, or the Delphi panel, they were not aware of that. I am aware because I work closely with hospice societies. We support them through seed grants, and we provide like, we meet with them and we hear from them regularly. So
Yes.
I'm aware of that, but I was surprised to that this tension point was actually about the understanding that grief and bereavement represents one of the core programs provided by hospice societies from the non-hospice sector. So it's I don't know if that is something that from long time ago, or this is something new, I don't know. But I hope that with the participation, or through our definition, now things are now much clearer than before.
I would also maybe just add to that I think, again, the tension, I'm not so sure about, but I also do think we are seeing an increase in grief improvement needs from the population out of COVID. The BC Center for Palliative Care, we're doing a bereavement project right now, and we've released the roundtable report on a roadmap for BC to improve bereavement care across the province. And because some of the findings that we have found are that since COVID, especially, people had really complicated grief coming out of the pandemic. And that grief was often compounded by job loss and these other kind of really complex situations in the last couple of years that are new. And even like that comment said, with the increasing toxic drug crisis happening, so there are definitely, in the last few years, I think it sounds like the hospice societies are doing more and more and more work in grief and bereavement, maybe more than the health system is realizing. So maybe the tension wasn't necessarily new, but just or changed all that much. It's more just that the services have increased so much since COVID. That might be an explanation.
Yeah, good point, Simon. Yeah, I agree.
Yeah, that's a good point. Sue has a comment about that. I think people are more comfortable admitting they are grieving, but saying you are dying is scary. Absolutely. Yeah. People are willing to say I need help, but to say I'm dying, that facing your mortality is, that's a hard one. Yes, absolutely, Eman. Just everybody on the line, if you have any thoughts or on the definition of the process, do reach out to Eman and Simon. They'd love to hear from you. Yeah, that's awesome. Another thing I'm curious about is just talking about the length of time. So it took 2 years to do a Delphi process, and I suspect you waded through a lot of data. Do you think, or is there a way, or how do you see a way forward to engage in a process similar to this, but less labor intensive with going through so much data, but with a similar like high quality outcome.
The Delphi process, let me begin and then I will let Simon add to the details of the Delphi process. But the Delphi process itself didn't take 2 years, but the conversations and the funding and, with the like partners who guided and co-led this project. It's just to clarify, I think an important point. This project was conducted without any external funding. It was conducted with in-kind contribution from the two organizations, the BC Center and the BC Hospice Palliative Care Association. So this is huge, right? We didn't like apply for funding or receive specific funding from any other organizations to conduct this. So doing a project with in-kind contributions takes time to identify the process and the resources and but I think the project itself, like the methods itself, the research, the environmental scan and the Delphi process, I would say maybe a year. And after that, there's time where we spend time putting together the report and the sharing. And so before and after the methods, implementing
There's a lot of kind of crawling through, really getting into the mud about these certain ideas, and clarifying and re-asking and all this stuff. But it was also on top of ethics approvals and just considerations as well. So I would agree with everything Eman said.
Yeah. Okay. Yeah. And that's so interesting. And, it just shows and highlights to me the commitment of the BC Center and BC Hospice Palliative Care Association to our provincial hospice societies and to the people we serve. It's like, if you're going to do a project, you're going to do it right and you're going to do thorough. And then what that means is that your results will be really applicable and they'll be really valid. So meaning that, you know what valid means. So I'm really appreciating that. And I did not know it was in kind. So wow, well done. That's a huge commitment. Everybody out there, like hats off.
Thank you.
Working from a nonprofit, and many of you there are nonprofits, that's a big commitment of your organization and your leadership. Yeah, wow.
But I have to say, it's also in-kind contribution from all the participants in the Delphi process, all the hospice societies, representatives, and the palliative care clinicians and experts, and even from other community partners like the Family Caregivers of BC, I don't want to miss anyone else, but there are similar organizations like the Family Caregivers of BC, community nonprofits in the working in the same context. They set the time to provide in-kind contribution to the development of this. So yeah, we should all. I just want to recognize their role as well.
Yeah, yeah. And we have a comment here that says exactly that. I loved being a part of this research. When I saw there was a survey waiting to be addressed, I would set aside time when I would not be disturbed to deeply think about my beliefs. So you had a lot of really committed folks to this consensus definition. And I think you achieved what you were looking for because 71 hospices in BC with a wide range of services. We have a hospice house, other people have different focus, and it applies to us all. So that's amazing. curious about, you know, when you're going to review the definition in 2 years. So is that in 2026?
Yes, that would be, so it was released in January 2024. So that would be in, yeah, the 26. Yeah.
Awesome.
But again,
And
it's in-kind contribution if unless we apply for external funding. So it's the exact timing. I don't think I cannot confirm it right now. So it will be sometime in 2026.
yeah, yeah. And I mean, you've just released this, it's hot off the press. What kind of feedback have you been receiving from hospices and the province of BC so far?
Amazing feedback. We did a webinar for it wasn't a webinar actually, it was like an online meeting or online session with the hospice societies, me and Pablita and Simon and Rachel Cotter from our organization, and Pablita from the BC Hospice Palliative Care Association, and it was an open discussion about like other parts of the or other nuances, and also questions about the tension points, and questions about like why this part or components, what is this wording, and we explained it's like how did we arrive, like more details and information about the methodology. But at the end, I received a couple of emails from Hospice Society's leadership thanking us for this remarkable work. After the release, I received multiple emails from federal organizations like Health Canada also saying that this is an important milestone, and I use that expression in how I communicated this on social media. They said that we are basically setting the stage or leading the similar work for other provinces. And Palliative Canada asked that requested our permission to use the definition in the Palliative Care Atlas that they are putting together for across Canada. So this is amazing feedback, and great to hear, very rewarding to hear how other people start using it or will start using it. So it's really great.
Wow. Yeah. And it's amazing. I'm using the word amazing like 5 times today because it is. But because you engaged so many people across BC, then I think that you've captured in such a rich way that it's more applicable. And like you say, Pallium Canada is pulling it in, and Health Canada. So then it's more applicable to all of Canada because you've captured the rich context of BC. And BC is very different from the rest of Canada. We have I think we've captured it all. Did you have any last comments or questions that you'd like to add before we close our time together?
I would love to hear from all the participants today about their thoughts on the definition or the process or any information that we covered, or maybe if you want to know more about the other tension points, we're happy to share that with you. So and if you have any feedback on the component or the wording of the definition, we'd like to hear it now. We are tracking all people, any feedback that we're getting.
Presenting on your consensus definition BC Hospice Societies, and it is National Hospice Palliative Care Week, so what a way to celebrate. And it's also Nursing Week here in BC. So a shout out to all our hospice palliative care nurses and to all our hospice palliative care associations and the great work that we're doing here in BC. So thank you and have a great day.
Thank you. Thank you so much.
Thank you, everyone. Thanks.
Bye.